typical symptoms of otitis externa is itchiness and irritation. There'll be loads of dry skin flakes in the ear. You can also get severe inflammation and swelling of the ear canal, causing a blocked sensation and earache, which would be what we call otalgia. Sometimes also with otitis externa you can develop ear pus, so what we call otorrhea. And patient attended with, as I said, otitis externa in both ears. You tend to find earwax in people with otitis externa is slightly more moist and mushy. Alternatively, it can also be a bit crisper and crustier. The wax itself, it just depends. And this patient in the right ear, the wax is a bit more mushier, and the reason for that is earwax is made up of many organic compounds, including 60% dead skin, so the skin that lines the ear canal as it sheds. It dies, and then it kind of mixes in with sweat and alcohols that are secreted by the ear, cholesterols, fatty acid chains, and all these components, organic compounds together, as they're kind of mixed, it creates earwax. And then in most people, so 90 to 95% of people, the wax naturally migrates out of the ear, so your ear is self-cleansing, self-cleaning. With otitis externa, you tend to find the wax is a bit mushier because there's a bit more dead skin. So it's sort of 60%, it could be 80%, 90%. And that skin, as it's dead and wilting away, it becomes damp, and therefore the earwax also becomes a bit damp. I might develop, so if you're a medic, you have the stool chart, so different consistencies of stool generally correlate with different health conditions, apparently, and perhaps I should do one for earwax. So I can kind of grade the different earwax. I have also like an earwax chart, so we can kind of grade different consistencies and types of earwax with different ear conditions. See, I've got the majority of the blockage there now. It's going to be virtually impossible for me to remove every little speck of dead skin and wax from this ear. It's just too mushy. It's almost like a soft poo, soft stool kind of consistency. So it's kind of all merged and stuck and adhered to the canal wall. But I'm just using a fine end gauge now just to mop up as much as I can. And this is why I find also an endoscope so advantageous compared to other techniques. We've just got a bit of dead skin that I'm peeling off the base of the ear canal there. With an endoscope, the field of view is unparalleled. You see the whole ear canal, and it enables me to manipulate the instrument with a far greater degree of certainty. I know whereabouts in the ear canal I am. With other visualization techniques like microscopes and head loops, you get, with microscope at least anyway, you get a fantastic magnification of the ear, but don't really know which part of the ear canal you're on. If you're looking at the eardrum, obviously you know you're on the eardrum, but even then you don't really see the whole eardrum in one shot. You probably see a quarter of the eardrum. So we're working very deep in the ear now, in the inner 2/3, where, again, if you've been watching my videos, you should be aware this part of the ear canal is very sensitive. It's literally a thin layer of skin measuring 0.1 millimeters in thickness, coating a piece of bone basically. So there's no fatty tissue, no cartilage. So if you do make contact with the bony part of the ear canal, believe you me, it will be slightly uncomfortable for the patient. So you can see we're just trying to avoid touching the bony part. I don't know whether anyone's played that game growing up called Operation, where you're trying to remove bits from different parts of the body, and if you come in contact with the fleshy part of the body, you get a buzz. So it's almost like that when you're deep in the ear. When you're in the outer part of the ear canal, then you can make more contact with the ear canal, because that's cartilage. You've got a bit of fatty tissue there. The thin's a bit thicker, about 1 millimeter in thickness, so 10 times thicker than the skin that coats the inner 2/3. And we've got a lot of mushy wax here and dead skin on the posterior canal wall immediately. We're not going to get all that out. And now that the blockage is gone, that should dry up and naturally migrate as that skin sheds. But I'm just trying to get as much out as I can. And again, we just want to avoid touching the canal wall. You will get some bruising, some blistering, and sometimes that happens. It doesn't matter how skilled you are, how much of a steady hand you are. Sometimes, so just to explain what I was saying, now we're on the outer part of the ear canal, the cartilage part, and you see there I was making contact like I am here. And that's because that's fine. So if you imagine your outer pinna, the external part of the ear, that's made up of cartilage, you can move that around, twist it, bend it. It's not painful at all. But the inner part of the ear canal is not the same. It's very hard, and as I said, you're just going to be very delicate. So I'm just at the top part of the ear canal. As the patient was very still and I felt confident enough, I just try to remove as much as I can. But in essence, the procedure is kind of complete already. The patient is taking some medication for his otitis externa. It's important with otitis externa, especially, you want to avoid water entering your ear. Water can exacerbate the condition. So I've just gone back in with the Zollner suction probe, the 2mm, the larger one, and here we're just making contact with the canal wall. It's fine. It's not uncomfortable for the patient. You can see the hairs there, so that means we're in the outer part. So these hairs grow in the first centimetre of the ear canal roughly. That's where all the hair follicles are. You don't often see hair deeper in the ear. If you do, it's probably loose hair that's been trimmed by the patient and it's flown into the ear canal, or hair that is kind of almost dyed and you're poking using a cotton bud or a Q-tip further into the ear. So that's the right ear complete. We're now using the left side. So the wax here, it's not as mushy, it's a bit drier. So I've decided to use a Jobson horn, trying to get in behind it, trying to prise it forwards, extract it forwards. So it just goes to show, same patient, different ear, different type of earwax. So I don't know why this is not as mushy as the right side. The patient doesn't report using drops in either side, so it's just DNA really. It's just this natural ear. Different compositions of compounds in both sides. And you do often find that in patients. Some patients that come really rock solid hard earwax in one ear, the opposite ear is not as bad. It could have been there was just more wax being secreted in the right ear, which caused as more of an acoustic seal. So with this left side, the ear canal wasn't fully occluding. I would say it's 3/4 occluding, semi-occluding. So there was some air going into the ear canal, which could have helped dry the ear in some respect. With the right side, the ear was completely blocked, and that could have caused a lot of sweat and humidity within the ear canal, which turned the wax a bit more mushy. So that's one plausible explanation. So you can see we're making steady progress here with the Jobson horn. The Jobson horn in the right side would have been a bit more difficult because the wax was fully occluding, so I would have to Jobson horn and ear hook, you really ideally want to use it where there's an opening where you can insert the instrument through a gap in the wax or in between the wax and the ear canal, get in behind the wax and pull it forward. When the ear canal is fully occluding, it's a lot more difficult. If you're working on the outer part of the ear, it's fine because, as I said, you can make contact with the canal wall. But if the wax is quite medial, which it was in the right ear, Jobson horn ear hook wasn't really the best choice of instrument. Sometimes we have no choice. The suction probe doesn't help, so we just have to evaluate each case as it comes, the risks in each case, and where it's needed, we just use it. But we try and avoid it if possible when we're going deep in the ear. Obviously, forceps wouldn't have been very useful in the right side because the wax is too mushy. So got all the lateral wax out, and as I said, whenever I'm working deeper in the ear, I always like trying to use the Zollner suction probe because you're less likely to make contact with the canal wall and you can just suck the wax out as opposed to getting in behind with a Jobson horn or ear hook and making contact with the eardrum, for example. So this wax, I brought it forward, wasn't coming out anymore, so there was a gap there, just gone back in with the Jobson horn, in and behind the wax, and there we are, it's a large chunk of dead skin and wax removed. There's the eardrum, fully visible. So with otitis externa, I try and remove as much of the dead skin as possible. It's not always possible to remove every little last speck. We'll be here all day if we're trying to do that, and you would just cause bruising and blistering of the ear canal. So you can see a bit of hair in the ear there, so a bit of cilia. So we know the camera is just located just near the entrance. Bit tricky because of the hairs, but just trying to get a better view. And there we are, just put the camera a bit further into the ear canal, resting it at the base. Got a big piece of skin. I'll be going in and out of the ear doing that several times, just trying to mop up, and again trying to avoid touching making direct contact anyway with the ear canal wall. And So it does require a steady hand and a lot of practice. Unfortunately, I've been hearing things and observing things via social media in the UK that there are some, I call them ear care practitioners, but I don't know whether I should, because they haven't received the relevant training in this technique. They've been performing earwax removal using different visualization techniques, and they feel, which is quite naive really, and a bit of arrogance I feel too, that they can just pick up an endoscope because they've removed wax using a different technique. And some of the videos have been quite horrific, if I'm honest. As a healthcare professional, we all have a duty of care for the safety and well-being of our clients, and I can quite confidently say that I'm very proficient using an endoscope, but I also do own an operating ENT microscope, but I didn't just buy it and start using it because I'm very good at an endoscope. I got myself trained by an ENT surgeon because it's a completely different skill set. So if anyone out there is booking in with a specialist, I would advise and ask what technique are they using, and more importantly, who's trained them in that technique, and whether, if they use several techniques, that they've been trained by a proper accredited specialist who has been trained themselves, because there is some people out there who've kind of almost self-taught themselves and become trainers, which is just ridiculous, absolutely. We have a similar problem in the UK with dermal fillers and Botox. In essence, anyone can do it. It's not illegal, as long as the person you're performing the procedure on is fully aware that you're not trained and you're just a lay person off the street. There is actually Botox parties in the UK. I don't know how it is in America, but your ear is very sensitive. It's a precious part of your body. See a specialist, make sure they're trained in that technique, and also always question who trained them. Have they got the relevant accreditation? So anyway, you saw some still images there. I went a bit off tangent. It's just a very relevant topic at the moment in the UK. I'm trying to raise awareness of that because it's not fair on the patients contacting specialists under the impression that they're trained in a certain technique, and they're not. We've also heard accounts that people using endoscopes are not disinfecting it as they should be. They're just using alco wipes, which is not the way you disinfect an endoscope. So they are potentially risking cross-infection and contamination between people's ears. So just a few pointers there, guys. I hope you enjoyed that video. I'll try and upload a couple more. I'm just at the clinic.